Ready? Okay, good evening, everybody. Welcome back. I know we took a month off there in August, so welcome to the September 2nd meeting of the Brooklyn Borough Board. As you know, my name is Andrew Gennardis, the Borough President's General Counsel. Thank you, everyone, for being here. We're going to get started. I'm going to start with the roll, and then we'll go right from there. I'll start with the council members first. Councilmember Levin's office. Councilmember Reynoso. Councilmember Cumbo's office. Councilmember Cornegie's office.
Michelle Gross, representing Councilmember Cornegie.
Councilmember Espinal. Councilmember Menchaca. Councilmember Lander. Councilmember Eugene. Councilmember Mealy.
Wiggins, representative.
Councilmember Barron. Councilmember Gentili. Councilmember Greenfield. Councilmember Williams. Councilmember Mizell. Councilmember Traeger. Councilmember Deutsch. Community boards. Community Board 1. Community Board 2. Community Board 3. Community Board 4. Community Board 5. Community Board 6. Community Board 7.
Here.
Community Board 8.
Present.
Community Board 9. Community Board 10.
Here.
Community Board 11.
Here.
Community Board 12. Community Board 13. Community Board 14.
Here.
Community Board 15.
Here.
Community Board 16. Community Board 17.
Present.
Community Board 18. Borough President's office here. That gives us 16 members present. We need 18 for a quorum, so a quorum is not established. As I said earlier, we will proceed with the meeting and take our vote on our minutes approval once we achieve quorum later on. Before we begin, I have a couple of quick announcements on behalf of the Borough President. First, you should have received, when you got here, a flyer about an emergency preparedness forum that we are hosting on Tuesday, September 16th, so it's 2 weeks from today, talking about how to be prepared in case of an emergency for hurricane season. We're still in the midst of hurricane season, amongst other things. So please take the flyer and pass it out to your constituencies. We'll email it out as well, so you can send it to your community board lists, your council district lists, and we're partnering on this with the Red Cross, with OEM, the fire department, the police department, FEMA, Con Ed, National Grid, and our office. So please spread the word far and wide. Yes?
Is that Wednesday?
Tuesday the 16th. Program begins at 6 p.m. and we are asking people to RSVP, but we'll send it out in a digital format so you have it, and please have your constituents come. And we'll be joined by OEM Commissioner Joe Esposito at that forum as well. Moving on, just a couple of quick additional announcements. On August 26th, the Borough President announced part of his capital budget allocation in the 2015 budget. He allocated more than $5 million in capital funding for parks throughout the borough. And then followed up 2 days after that, he allocated $7 million in libraries and cultural affairs institutions, including the Brooklyn Public Library, the Aquarium, Brooklyn Academy of Music, the Botanic Garden, St. Anne's Warehouse, Prospect Park Alliance, and I'm sure I'm missing a whole bunch, but making significant investments in Brooklyn's cultural institutions and its open spaces, its schools, and among other places. Also, we have been actively involved in working on getting the Democratic National Convention to come to Brooklyn in 2016. I'm sure you've been seeing the buzz about that in the papers. There was a site visit by the DNC in the middle of August for 2.5 days that the Borough President was a part of, working with the Mayor's office at NYC and Co. and others to lobby the DNC to choose New York, but really Brooklyn, as the site of their 2016 convention. So we'll keep you updated as those things develop. We're really excited about that. We think we have a really good shot at making that happen, and that would be a huge boon for Brooklyn if we're able to host the convention here, right here in our own backyard. So with that, Are there anyone else have any announcements they want to share, council members' offices or chairpersons, before we continue? Okay.
I'm sorry, is this where I can make an announcement that Community Board 17 has moved? We have a new location?
Can you speak into the mic, Gail? Thanks.
Community Board 17 has now relocated to 4112 Farragut Road between, it's on the corner of Albany Avenue. The phones are not in as of yet. Hopefully we will get them in this week. The staff is there working, trying to get the office ready for the constituents. Thank you.
We've just been joined by, which office?
Community Ward 12.
Community Board 12, perfect. Okay, and with that, actually, we do have a quorum. So at this time, I'm going to ask to have the minutes of the July Borough Board meeting adopted. Copies were sent out. Motion to adopt. Are there any, I know there were some corrections that were passed down earlier before the meeting to me, some minor grammatical errors. We will make those. Are there any additional discussion? We have a motion, we have a second. All in favor? Aye. Any opposed? Okay, terrific. Thank you. Okay, moving right along. That motion passed. Minutes are adopted. Moving along, our first agenda item tonight, or second agenda item tonight, is a presentation from Councilmember Reynoso's office on City Council Intro number 409, a local law in relation to regulating publicly accessible collection bins. You all should have received a copy of the legislation in your email packet as well as when you walked in tonight. And as Councilmember Reynoso's office will explain, this is really about regulating those clothing charity bins you see popping up on every corner and everywhere across the city. So there's current legislation on that. I'll let the council member talk about it, and then we'll take some questions and we'll go for a discussion based on that. Lacey?
Thanks. My name is Lacey Tauber. I'm Legislative Director for Councilmember Reynoso, who, as you all probably know, is Chair of the Sanitation Committee. So this bill is actually put forward by Speaker Mark Viverito, but I think there were probably 8 council members who had, bill ideas about this issue. If you guys all saw, in July, there was an article in the New York Times that brought up the fact that this issue has really proliferated recently. These bins that we see, on the streets and sidewalks. According to the article, in 2010, in the whole year, the city tagged 91 bins and confiscated 10 of them. And just this year, up until July, they tagged more than 2,000 and confiscated 132. So for some reason, this has really been a growing problem that a lot of community boards and bids and others have called to the council's attention. So this bill is really a response to that. And basically the way that it works right now is if these bins are placed in public space, then the Department of Sanitation tags them, and it gives the owner of the bin 30 days to remove it. But what we see is actually just that the owners of the bin then just maybe pick up the bin and move it somewhere else. And it's really hard for the Department of Sanitation to regulate. And this is an issue partially because it affects the city's diversion rates for recycling. And a lot of these organizations that are putting out these bins, some of them are legitimate nonprofits, but many of them, like the Narciso Recycling that you see a lot all over the city, those are actually a for-profit business who are taking this recycling, the textiles, and selling them to thrift stores or even overseas, and doing that at a profit for their company, while they're claiming on the bins to be a nonprofit that supports jobs. And so the city's looking at this bill as a way to sort of crack down on this issue. So intro number 409 does a couple of things. One, the city can't really regulate whether or not these bins can go on private property. That's at the discretion of the owner. But what it can do is require registration of the bins on private property and reporting on what's collected in those bins. And that gets to the question about diversion rates for recycling, so the city can take that into account. And the really important thing is that for public property, what it does is it empowers the Department of Sanitation to immediately remove the bins from public property, and the owner then has 30 days to claim the bin from the Department of Sanitation, or they can just get rid of it after that. It also attaches some fees to this. For non-compliance with the piece dealing with private property, there's a $50 fine for the first offense and $100 for each subsequent offense. For the bins in public property, it's a $250 fine for the first offense and $500 for each subsequent. So it's fairly significant, and also the bill would allow the commissioner to set other fees attached to this based on removal, storage, disposal costs, and the registration fee. So we're going to be holding a hearing on this bill here at Borough Hall on Friday, September 19th at 10 a.m. And we encourage everyone who has, been affected by this issue to come out and speak. We're not anticipating a lot of opposition. We're hoping that it will pass pretty easily, but we'll see.
Thank you, Lacey. Any questions from members of the Borough Board? I can say, on behalf of the Borough President's office, we, in talking with district managers, through the Borough Service Cabinet, and also talking to bids across the borough, these charity bins have been a really big issue. So we're hearing it anecdotally from all across Brooklyn about how they're just proliferating across our sidewalks, and people are really hoping that we can do something strong to combat that. So we think that this legislation is a good step in that direction, and we're happy to host the hearing here at Borough Hall to help advance the legislation to that next stage. And when the time is appropriate, we can hope to, urge the council and the mayor's office to both pass it and then sign the bill. Any other questions before we move on? Okay, terrific. See, we're just rolling right along over here. Next, our next agenda item, actually before we continue, we've been joined by Councilmember Cumbo's office. Brian Cunningham's here from Councilmember Cumbo's office. Our next agenda item is a presentation by Grace Wong from Downstate, SUNY Downstate, on the Brooklyn Healthcare Improvement Project. Now, some of you may be familiar with the work of BHIP, as it's called. Others of you might not be, but they've been doing a lot of great work across Brooklyn for the last 5 years, and they meet here at Borough Hall, and it truly is even though the map shows us half of Brooklyn, colored in, it really is a borough-wide effort and a borough-wide initiative. And as they continue to do their work, we think it's great to loop in partners such as the council members' offices and the community boards to see what they're doing and to become a part of it. So with that, I turn it over to Grace.
Thank you very much. Do I need the mic? Thank you very much to invite me here today, and then some of the members in our team. It's a very exciting project for us. When we started that 5 years ago. Oops, wait, I'm going too fast. Okay, so actually we started this thing 5 years ago because for New York City Department of Health gave us a grant, like $962,000. And then that grant is a 3-year grant, and then our goal at the time is really trying to figure out to build a multi-stakeholder coalition and for community planning efforts in central and northern Brooklyn. And then we try to come up with a vision for central and northern Brooklyn and how that vision is going to be accomplished. Now, just so you know, for the 15 zip code area, there's like 1 million people who live there. And one of the other things is that we have to specifically address the ED utilization, the emergency room utilization, and trying to, at the same time, build a large database and look into the primary care utilization, how that works. So this is a pretty big goal. At the beginning, it's really 2 years because you know how the state funding, right? You never really get the money until like 8 months later. So, but we start doing our work. Our membership involve a lot of community organizations. Some of you, you know who they are. Brooklyn Perinatal Network, Brooklyn Congregated United. So in a way, we have around 30 some organizations put together. including the Borough President's Office, New York City Department of Health. We also have community-based federal qualified health centers, including hospital partners. At the time, we only have like 6 hospital partners at the beginning. But by the time we complete our project in 2012, which we issue a report, we start building it, and the last time we count, except 2 facilities, they all in our project. Okay, we also have insurance partners because we can't talk about healthcare without insurance company to be our partners. So we started with 9 insurance companies. Now many insurance companies become our partners. It took a long time to build. We also have WCBS working with us, including pharmaceutical company, United Hospital Fund, and KPMG. When we went through this project, we have to figure out what is our mission and vision. If you think about 30-some organizations try to get together, we don't know each other, but try to figure this thing out. It took a while for us to really decide what we really wanted to do. So after like 6 months deliberation, we come up with something really simple. We're saying our mission is to improve the wellness of our population by addressing access, quality, and cost. In central and northern Brooklyn, we're pretty focused at that time, just for that geographic area, 15 zip codes. And our vision basically to ensure access to affordable, quality, and timely care for all the residents in the area, so effectively eliminating disparity in health outcome. It sounds this is a very aggressive goal, very aggressive. Are we going to do it? Yeah, we're going to do the best we can. We're going to work until we achieve some kind of disparity, eliminating disparity, and through coordinating health system planning process and engage and foster multi-stakeholder engagement. So we went through that, and what did we do? We said, well, in order to do this, achieve this goal, we need something really real. We need to look into the 15 zip code, what is really out there. Actually, we started a canvassing project, really block by block survey to see what is out there for our own eyes, right? Because everybody can search through the web, everybody listen to everybody, have a directory. It might not be real, we don't know. We're also trying to look through the emergency department for all the six facilities. We went through 4 weeks, 24/7, a different period of time, to interview like 12,000 ED patients. 12,000, that's a lot of patients. We interview 15 minutes each, try to see why they use the emergency room, to talk to them. We also work with 400 providers, the folks who actually work in the ED, provide the services. What did they think about why people using healthcare services? We analyzed more than millions of data set from the state planning data set, as well as the insurance partner. They have to give us encounter data, how they use insurance. Of course, everything is privacy protected so that we can do the study and then just not violating anyone's privacy. So when we went through that, this is the people who actually help us to do the canvassing. We went through block by block survey. This is like, we actually hire people from the community so that they understand how it works, and then we informed the prison before we went out there, because some of the neighborhood might not be the easiest thing to do. So our results tell us that what we did is that when we go through this whole thing, we took all the insurance companies' roster, the major insurance roster, like a book. You're all participating in health plans, right? And sometimes you need to know either our doctors in network or out network, right? So we put all these things together And then we survey all that and see if this is really real. We find out 21% of all those providers are really not on the list, or they're not there. They might be, there's an office we visit, we use the exact address, maybe they have McDonald's there. So in a way, this is some really enlightening if you are relying on the directory to see a doctor, try to make an appointment. It could be very frustrating if it's 21% time, you don't get someone to do that, right? So that's something we find. We also find out something really interesting is that in this geographic area that we have, wait, let me see if I can maneuver this a little pointer here. We have a hotspot. We told them there's a hotspot area in this red area that we block by block survey. Now, usually by zip code is really difficult. We know that in New York, it's different than some of the other area. In one block, you might have a luxury housing. On the other block, you might have projects. So in order to do that, we really went through a really finite way to look at how people access the healthcare system. So this graphic basically telling that a lot of the admissions in this geographic area, we have a lot of them, is that not avoidable admissions. They wind up in the hospital. They don't really need to be in the hospital. Okay, those, we call it the hotspots. The hotspot, you know, you see this area in the Bronxville area, East New York, Bastine. So we know that those are really, and a lot of these so-called avoidable admissions are asthma cases, like CHF cases, diabetes and stuff like that. So what we're trying to do is trying to figure out why people are using all these services. And after we survey that, we also find out is it because we don't have enough primary care doctors or not? We find out that for one primary care doctor, based on Medicaid regulation, they should be able to see 1,500 patients. Now, by that definition, we have enough PCPs in some of this area. But how come people have no access? You see, what's happening is that, you look, we said that some of the area is that the PCP might have it, but they're not evenly distributed. Now, we call this the shooting map. The shooting map is that it was in the New York Times, Wall Street Journal back in July 2012. They identified which part of Brooklyn, actually New York City, a high crime area, you know, there's more shooting. This is by NYPD's report. Okay, so we know that in some of those areas, a lot of crime, we don't have a lot of providers out there. They don't want to practice in some of those areas. So, and this is some of the demographic area that who are using the ED. We find out that based on Brooklyn, you know, this is by race, you know, how many, so saying that in Brooklyn, 43% are white, 34% black, 11% Asian, and then 12% mixed. But if you look at the survey, when we're going through the emergency room, it's a very different population who use the ED, okay? And also, it has to do with the income level and education level, how things is being used. So the important finding that we find out is based on this map. I don't know, can you all see that? So when we go through the 12,000 survey, we find out 43% of the patient, they actually self-identified. They didn't come to the emergency room because it's emergent. They come in here because they come in here for convenience, and this is the things that they always want. They always go to the emergency room, or they can't reach their PCP, or they can't, or they don't have a PCP. They were told by their doctor to come over here. So this is very enlightening that this is self-identified 43%. They said, it's not emergency. We're just coming here because the way we're always doing it. Then we tell them that, well, where will you go if the hospital is no longer there? If there's no ED, what do you do? So 65% actually saying that we're just going to use we're just going to find another emergency room. So this is the way for a lot of people, that's how they access care. And then we know that there's a lot of education need to be done. Why? So based on this, because we also ask a question, do you have a PCP or family doctor? But by some of the statistics that we see, for example, the one in red, Child Health Plus, Family Health Plus, and Medicaid Managed Care, by definition, by law, you have to have a PCP. But when we ask a question for those people that have those insurance, 14% they said, I don't have a PCP. 3% say, I don't know. So that's 17% of them, they don't know that they even have a PCP. So a lot of time it has to do with how insurance works, right? And then you can say, oh, because you don't open a certain time. But if you look at the arriving time in the ED, a lot of times it's during hours that the doctor's office is open. So in a way, is a primary care the solution, or is lack of quality primary care? That's become a key issue there, right? So we also went through a lot of the insurance data and looking at before the patient hit the emergency room, 1 week before or 4 weeks before, do they even see a doctor at all? Well, not everyone see a doctor. They just hit the emergency room, things happen, they just go. And then even afterwards, they're not really totally using the ED, following up with their PCPs. So we said that, this is a very busy slide, but what that tells you is that if in our BHIP study area, the 1 million people, and then if they behave the same way like the non-BHIP study area, like the other zip code area, just by the saving in terms of ED visits, the admissions, we can save just in Brooklyn alone, potential savings of 145, well, actually 465 million a year. That's a lot of resources that we can save. And if we're saying that if we're going to be just like average in Brooklyn average, we're talking about 145 million a year. So what we're saying is that there's a lot of wasted in healthcare dollars, and then what that dollar can be better spent so that we can improve the outcome for the geographic area, because the geographic area, when we look at it, the health outcome is one of the worst in the county and actually in New York City in that geographic area. So we say, how might savings be realized while improving quality and assets? We're trying to say, what should we do? Then we're just saying that, okay, there's something that so 2012, after the study, we issue a report. The report, by the way, is in the internet. If you just Google, Brooklyn Healthcare Improvement Final Report, you will get that. It's right in the internet. As a matter of fact, we're proud to tell you that the first month when we issued this report, there are 47,000 hits. There's a lot of interest in the people actually look at this report. So, after we issued this report, we really spend the next year try to really figure, well, after the project funding is gone, and then since we've been working 3 years together, all the membership basically saying that we don't want to go away from each other because we learn so much from each other. So we'll continue without the funding, and then we come up with this solution. We're basically saying that we need, in order to reduce avoidable emissions, and in central northern Brooklyn, and then achieve 25% the avoidable emissions, we also sustain this. We need to do 3 things. So one is to coordinate and standardize care management among the provider partners, redirect patients to appropriate settings. This is coordination of care. The second piece is really patient engagement. If we don't engage our patients and then we don't talk to our patients, we can set up anything we want. We will never going to change the way people behave. People are going to use the system. And the last thing is that in order to keep the facility alive to still there, we have to engage our insurance partners. We're talking about insurance reform. So there are many steps we think that we need to do, especially the navigation center right next to the ED. So we agree with this. We said, well, in order to come with something like that, we need some kind of funding. So one of the ideal thing we say, oh, maybe in all the emergency room, we should have a patient navigation center. So when patient treated and admitted, then they can be having someone coordinated care either after they back to their PCP or work with community-based organizations. Or people who treated and released in the ED, we can go back. Like someone is a quarterback for the patients so that the patient would not be lost in the system. So by doing that, while we go through this thing, there's such a magic word come by. The New York State just got the $8 billion Medicaid waiver. They call it DSRIP, Delivery System Reform Incentive Program. So payment program. So in a way, what we're trying to do is that everything we laid out the last year wasn't wasted. So what we have to do is that we try to work with the SUNY-led so-called provider performing system, and then come up with different ways so that hopefully we can get some of the funding to implement this vision. Why are we doing that? So this is a navigation center. If you look at patient come to the hospital, they really have to go into the ED, right? Come to the ED, and then we have patient navigation so that we can navigate them to different areas so that we can make this thing work. There's another thing is that we know that with the hospital system, when a lot of patients, they finally coming out from the hospital, hospitals are shrinking. We know that there's a lot of bankruptcies in Brooklyn, a lot of hospitals in trouble. And then when the patients start being coordinated outside of the hospital is going to shrink. And then in order for hospitals to stay alive, they have to have economy of scale, right? So some of them, they might have to coordinate, some of them facility might have to be repurposed in something else. And so that hopefully we can achieve that economy of scale and then navigate our patient to the right place. So our proposal, when we're going through all these things, is to radically redesign the way the healthcare system assessed, financed, and delivered. So what we're trying to do is the intervention will combine in a streamlined, evidence-based management across the spectrum of local and healthcare providers with consumer-driven and patient and community engagement strategies. This has got to be priority number one. Because without the engagement with the community and consumers, nothing is going to happen. We don't believe anything is going to happen. And also, we want to say we would target the Brooklyn hotspot area. So trying to get the most bang of the buck is what they say. So hopefully we can reduce all these hospitalizations, and then we're trying to build a multi-tier incentive payment model, and participate in shared savings, with our partners and with the insurance company. And we also trying to figure out how to transform the Brooklyn Safety Net Hospital into financially viable organizations with a clear role in improving population health as well, and come up with a delivery model that was self-sustainable, because we can't just ask for money. I mean, this is something we have to figure out how to do it ourselves. And we might even need to redesign the benefit package so that make it more attractive and then stimulate healthy behavior. This is something that we think that might be able to do. At the meantime, we try to collect a rich database so that we can measure our progress, what we do, whether it works or not working, not just talking, but everything is data-driven. So I wanted to tell you what we're doing right now. So this is what we've done in the past, and then we did last year, and what we're doing today. What we've been doing today is that we're working with, I just said before, working with SUNY-led provider performing system, hopefully trying to get the money from DSRIP so that we can implement some of those objectives we've been talking for the last few years. There's another thing is that in this funding, we call it Domain 4 funding, meaning population health management. Now, you know that population health in Brooklyn, a lot of the disease really has to do with the top 7 mortality type of diseases, has to do with 3 things. We call it DOS, not this operating system. It's called it diabetes, obesity, and smoking. So if we taking care of one of those areas, and also HIV is one of the top 7 too. So if we take care of some of these issues, then it would take care of a lot of the disease line that we have. But how do we do that if Brooklyn's going to have different group to do this? It's going to be very difficult. So what we did is that we convinced New York City Department of Health to take on the project for the whole city and for Brooklyn, so that we can combine all the resources together and try to advance a public health goal and work with BHIP to achieve that. That's one thing we're trying to, hopefully the next few months we can achieve that. The second piece is that we actually, this is very interesting. Andrew just mentioned about disaster preparedness. We actually have a funding, $150,000 with one of our offices with Bonnie DeColler trying to talk about disaster planning. So they have a lot of meetings already. And that team is actually the team organized 2010, the World Cup in South Africa. So they really know how to deal with disaster planning. And there's a lot of, they're doing gap analysis, have been doing this. So we started last year, and this year, hopefully we'll get funding for another 2 years. There's another thing that we're doing is that we trying to get funding for FAM project calling Filling Affordable Nutritious Project, which has to do with the obesity project that we have. We have been submitting things to our Aetna Foundation, different foundation. We're still waiting for results to come. Also, there's another thing is the CAMBA project. This is a maternal, infant, and child health collaborative project, which we obtained $1.45 million together with CAMBA to start this project. This project basically is trying to reduce preteen pregnancy and also preterm labor, because you can see here, just look at the map. Here, the area that we have the most emissions is also have the highest death rate per 1,000 live births. So, and also if you look at this, and then for preemies is also in this population. So we're focusing the 4 zip code to work with them. Now, the takeaway for this whole thing is that in our study areas, 5.4% of the New York State population, but use 10% of all this, for the medical charges, just for, compared to inpatient emergency room and ambulatory surgery procedures. So we know that as a high utilizer in doing all these things, and we trying to figure out our proposal will serve as a catalyst to really start addressing the Brooklyn solution. We're also looking at the primary care sites, because we look at a lot of these primary care sites is it because primary care, they are not really fully utilized. A lot of time people saying that we're going to invest in primary care, but you know what? We find out doing the canvassing project, not all the primary care offices are being utilized. You ask the doc says, oh, okay, see a patient tomorrow. But some of them is that patient's not going there. They go to the emergency room, or they go to the busiest provider. So we're really dealing with a quality issue about some of those areas. We might thinking about, this is more than just primary care. People are really looking. We have to start listening to our patients. Because patients say that we want one-stop shopping, not just primary care doctors, because if you go to PCP alone, you might have to get another cardiology visit, this visit, that visit. You have to get out from work. You could get trouble with your boss. So we're talking about, we have to figure out somehow how to meet their needs in terms of one-stop shopping. Maybe, we might need multi-specialty site imaging urgent care centers or something like that that we may be able to do. And, you know, we talk about Medicaid policy, the state. We tell that the state is a random dating game because the way it works is the state will assign a patient. If you don't choose your PCP, they automatically assign you a primary care doctor. So a lot of those patients, they didn't even know. They have no idea who their PCP. As we studied, 17% of the folks didn't know who's their PCP, right? So maybe the state should mandate, you know, the mandate if you take care of Medicaid, if you want to take Medicaid insurance, maybe you need to at least show up at the first date to see a PCP. Because for all the commercial insurers, many commercial insurers saying that if you don't show up, we're not paying for your insurance because we can't engage you. So that is something, maybe something we want to look into. And the state, we asked the state, this is 2 years ago now, we've been asking the state, make sure that this insurance company come clean with us. When they put some of the provider on their directory, make sure that they are good directories so that would hopefully will reduce you know, the error rates. So when patient needs the directory, they know where to find the doctor. So those are just some of the takeaways. I hope I'm not boring you with this presentation because it's a lot to absorb. But if you have some questions, I'd love to answer some questions. And yeah, questions? Yeah.
Your slide on page 19.
Yeah.
What is PCMH?
A patient-centered medical home. It's a patient-centered medical home. Basically, it's almost like a care coordination in the functions like a health home for the patients. So it's more coordinated care.
Okay.
Yeah. You know, I'm extra grateful that Andrew, you know, invite us to be here. And one of the objectives is this. If we are going to get the domain for meaning that do a public health project, there's a good chance we have to go to every one of you to ask for your support. Because this is a project for Brooklyn. And you know, if we're gonna do, say, one project on HIV, this is not just Central Northern Brooklyn, this is the whole Brooklyn. We are planning to expand this thing to the whole Brooklyn, and then I think a lot of this community board needs to be involved, because it's not one organization, not New York City Department of Health, not BHIP, it's every corner, everyone needs to be involved. Yes?
You say that you want to expand.
Yeah.
What are your goals
The goal?
for expansion and where?
Okay, so the expansion is that right now we target Central and Northern Brooklyn. But however, if we are going to take over one of the so-called public health project, we can't just say Central and Northern Brooklyn. We have to say the whole Brooklyn, right? And then now in our membership, so SUNY-led PPS, Provider Performing System, this is one entity. You have partners like Methodist, you have Maimonides, you have Brooklyn Hospital, they all there. So in a way, you can't really just say, okay, if we talk about HIV, stop HIV, or we want to talk about smoke cessation, we can't just say we stop here, we don't do the other part. So saying that if we want to have a media project, saying with WCBS, they have a community assessment project. So we want to roll it out to the whole Brooklyn. So it's much easier because this will be a public health project. And then I think that every community board, I gotta believe you have a health committee and get them involved as well. I mean, I used to be community board 6 in Manhattan, just many moons ago. So I know their health committee in Manhattan. And the thing is that we'd love to take a public health project. And so in a way, you know, there's so many health projects you need to do, but if you do so many things, it doesn't work. But if we want to focus on 1 or 2 and saying that let's have a goal, we may get there somehow. And then if every community board, city council support one project or two projects, I think that we can make a dent in some of these initiatives. Because you see, this is one thing. Grandpa taught me one thing. So I talk of Grandpa. It's like eating grapes. I used to just like, I love grapes, but only sweet ones. And then if it's really good, I just get a mouthful. But when you eat so much grapes, you choke. So you want to take a couple at a time. It'll be really yummy, and then you can taste it. So in a way, I think that when you do the project, there's so many projects, you can't do them all. Because we only have, so in a way, when we're doing all this district project, it's only a 5-year project. 5-year funding, so the first 1 year, 2 years is trying for you to plan to develop, get a partnership together. And then the 3rd year, if we don't achieve our goal, we don't get our results. We don't get paid. So basically, New York State, in order for New York State to get that $8 billion, CMS, Uncle Sam said, you have to meet your goals. And then if you can't meet your goals, the money go back to the federal government. So in a way, whatever we take, we have to say, seriously thinking about what is real, what's not real, right? And if this is something that we can't do, we don't want to take too much. But the thing is that we need to stretch ourselves. We can't say that, oh, we just do the easy ones. So for example, we are working with Campbell on maternal infant collaborative project. So we know that we're working on it already, so we didn't pick that because, you know, that means double dip. We don't want to double dip. We want to like make sure that we work on some project that will make it, you know, public health progress in public health arena. Any more questions? Yes.
Would you recommend coming into like our one of our health committees and talk to them first as they set up like a health fair? You'd be somebody from your group would come out and talk at the health fair.
I think that will help. In a way, it would be even nice that once we have a BHIP meeting, we invite all the community board healthcare committee to join us. We have the committee here usually in Borough Hall, and then, you know, they're really generous with us. They, you know, to use their room. We used to meet every month. We actually meet every month, and, you know, when there's project deadline, we meet every week, literally. They're trying to get together, so we'd love to, you know, invite all your healthcare committee members to come here to, you know, brainstorm. Because, you know, I think that usually when folks get together, have different opinion, you really come up with good ideas. And I think the BHIP project is just testimony of everything, all the work that's being done by all the coalition members. You're talking about 30-some-odd organizations now. It's like, well, we know that 50-some-odd organizations, we know them well, we're working together. But within 1 month, once the $8 billion come along, suddenly our membership increased like 100 of them. And then we say, well, who are they? Some of them we never heard about them before, but suddenly said, we want to be part of you. So now we have a courting time, right? We really need to know who they are. We need to know what can we do together and how can we coordinate the care. So I think that with the community board together, that would be really awesome to just get to know each other and start working together so that we don't working in silos. So not everybody working in the individual project, because anything about public health, you can't make too much improvement if you just do like one little thing. But sometimes, you know, a little thing, we could say that this is a demonstration project. We'll focus on doing that. Once we know how to do it well, then we can scale it up, you know, to replicate it across the region. Yeah. Any more questions? So thank you very much to give us the opportunity. Thank you.
Thank you.
Thank you, Grace. Just so you know, and Grace alluded to this, I mean, we all know it's no surprise, no secret about the healthcare crisis facing Brooklyn. The hospital's under enormous pressure, hospitals closing, hospitals going bankrupt. And you know, before this project came on the scene a couple years ago, we really did not have good data to really understand why all these pressure points are being created across the system. And so now that BHIP is mapped out where a lot of these pressure points are in a lot of the high need areas, we can start making educated strategies. We can start implementing strategies, rather, to start tackling some of these problems. I mean, you said 41% of hospital emergency room visits were unnecessary. I mean, that's an enormous number. And then it's incredible to see what that data shows. So we think BHIP's doing a terrific job, and as they continue to work on these projects, looping us all in and getting all of our community partners involved really will help make a big difference. And there is no one answer for every hospital or healthcare problem in Brooklyn, but if we have the right data behind it, we're able to start tackling these things one at a time, as Grace was saying. So for those of you that are interested, you can talk to Grace after the meeting. Like she said, they meet here every month. They have a meeting here this coming Thursday morning, and really being a part of the process. And if they're not working in your areas right now, at some point they will be. And it's critical that we tackle the issues that need our most immediate attention right now, and then start expanding from there to covering the whole borough. So with that, thank you very much, Grace. So I know we were joined by 2 additional council members' offices during the presentations, Councilmember Greenfield's, right, and Councilmember Menchaca's office. Thank you guys for coming. And with that, that concludes our agenda for the evening. Are there any other announcements from any board members before we? Okay. Our next meeting will be Tuesday, October 7th. And I know you guys don't want to do this, but I'll entertain a motion to adjourn. Motion to adjourn. Is there a second? Are you sure? Okay, motion is seconded. All in favor? Aye. Okay, great. Thank you very much, everybody.
Thank you.
Yes.